tell me if this is one of your pet peeves, because after listening to all these case studies and listening to their suffering, it's now one of mine. I'll say a caveat that OCD, the disorder, is very different than the personality type. It said, all doctors should have some OCD personality type, because if you don't worry a lot about, making a mistake, you might make one that could be avoided. And that's one of my best friends who's a surgeon says that, and he's an incredible surgeon. So I'm constantly thinking about, drug interactions and new protocols and things like that. Or if I've got a complicated case, that's not OCD, right? It's OCD is one of those terms that's thrown out a lot, like a picnic blanket, and it really does to me. Now I'm mad. I don't even have OCD, and I don't like when people say it because of all the suffering that happens. Like, there's a huge difference between worrying about maybe getting on a plane. Like, my son, when he was 5 or 6, decided he's not getting on a plane, and he went to therapy, and we did a segmental exposure, but it's not the same thing as OCD, right? I mean, what are your thoughts on that? And please tell me you're at least a little bit as mad as me. Otherwise, my anger is displaced.
I don't know if it frustrates me or makes my blood boil, and I've actually kind of coined the slogan around it, which is that OCD is not an adjective, right?
I love that.
You wish you had a little bit of OCD. No, you don't. OCD is not helpful. OCD doesn't make you a better surgeon. OCD doesn't make you more organized. It doesn't make your kitchen more clean. OCD is destructive. It's disabling, and it impacts and ruins every facet of someone's quality of life. Now, when we think about obsessive compulsive personality disorder, right, OCPD, that might be more of what some people are talking about, right, which is that, like, a lot of surgeons do talk about when they're in the operating room that they like their instruments laid out a certain way. They like it handed to them, and they talk about how it actually makes them feel less chaotic, right? It feels more organized. It's how they function, and it's kind of something that, like, soothes them, right, that there's a system in place. That is not OCD, because, again, OCD is destructive. OCD is not helpful. OCD brings no pleasure. There's no enjoyment in it. That may be OCPD, obsessive compulsive personality disorder, but, again, that is totally different presentation-wise. And I kind of get frustrated that they even allude to being similar, because it makes people think that, people with OCD don't really hate their obsessions or hate their compulsions. Yes, they do. These are unwanted intrusive thoughts followed by repetitive behaviors that we do to feel better. We don't like the obsessions. They cause us extreme amounts of anxiety, distress, and we hate the compulsions just as much. We don't want to do them. We don't enjoy them. We do them because we feel like it's the only way to feel better. And so my response or the biggest thing I would say is OCD is not an adjective, and there's not many things that frustrate me more than when people use it as one.
For our listeners out there, I was just wondering if you might share a little bit about this idea that people sometimes talk about, that OCD manifests around areas that are closest or most important to you.
100%, and it does. So really what we find is that OCD often attaches most to our values, our relationships, our faith, right? Things that mean the most to us and that feel really, really scary, right? It's pretty rare that someone with OCD is anxious and worried about something happening to, like, a random stranger that they don't care much about, right? Maybe they have that fear too, but usually it's, the core fear is usually, am I a bad person? Did I cause harm to someone else? Is something bad going to happen to me? Am I true in my faith, right? Is this relationship real and meaningful? Did I lie? It's often rooted in morals and values. And does that mean that OCD has to be rooted in morals and values? No, but what it tells us is that OCD latches on to the things that mean the most to us, right? People with OCD don't have unique thoughts. They did a research study where they were looking at people with OCD versus people without OCD's intrusive thoughts, and they had them both record them into, like, a video recording, and then the therapists were going to decipher who were the individuals with OCD and who were the individuals without. Guess what? Like, they couldn't differentiate, because everybody has weird thoughts. Everybody has bizarre, intrusive thoughts. The difference, though, is how we respond to them, right? Most individuals have driven down the road and had a thought of driving their car off the road, right? And they think, it was weird, and keep driving and don't think about it again, right? And forget they even have the thought, to be honest. Versus someone with OCD has that thought and might get stuck on, does that mean I'm going to do that? Does that mean I want to hurt somebody else? What does that say about me? What does it say about who I am as a person? Like, maybe I shouldn't be driving. I must be a danger to the road, right? And next thing you know, they're engaging in avoidance behaviors or compulsions or reassurance seeking around if they hurt someone, if they're going to hurt someone, if they might act on it. And so we do find that OCD, at least it attaches to the things that mean the most to us. Are the thoughts specific and unique? No, but if you have random thoughts and they're focused on things that are really valuable to you, it makes more sense if you have OCD that that's where it grabs a hold versus things that aren't really that relevant.
One of the favorite things that I like to talk about with patients with substance abuse disorder, among other things, is that there's this urge to try to control things, right? The uncertainty of life is one of the driving forces. So because life is uncertain, that's just the way it is. The Greeks knew this, which is why the Oracle at Delphi, which was the prophet they would go to, or at least in the myths, to get answers to perplexing questions, always was answered in a question. Addicts will try to control things. Actually, people with mental disorders, I want you to maybe speak on that, because eating disorder is the same thing. It's a type of control. And if they've got an eating disorder and they have a substance abuse disorder, when they get in treatment, oftentimes the only thing they can control is their consumption. So that will come up. So what are your thoughts on the whole, like, learning to deal with uncertainty in terms of recovery from OCD?
Yeah, that's the entire principle of treatment, right? The entire principle of OCD treatment, no matter what we do, is about being willing to be uncertain, being willing to lean into that, right? The reality is that where OCD attacks is, I want to know. I want to know I didn't hurt someone. I want to know things are okay. I want to know something bad isn't going to happen. I want to know I'm safe. We never know, right? There's not many things in life we're totally certain about. Now, of course, OCD takes it to the extreme, right? If you ask me right now, is your mom okay and safe? I would say, yeah. And you'd say, well, how do you know? And I'd say, well, I just kind of trust that I haven't heard otherwise, so I know. Do I actually know for certain? Of course not, right? But I'm leaning into uncertainty enough that, like, I don't have a reason to believe otherwise, so I'm just not going to spend my time worrying about it. Compared to OCD latches onto that, right? I want to be certain. I want to know for sure. I've got to call her. I've got to talk to her. And if I can't get a hold of her, then I'll call someone else. And as soon as she answers, I'll feel better. But then in 5 minutes, I need to call again because I'm not sure. So really, the whole principle behind OCD treatment and ERP is that we're leaning into uncertainty. We're willing to live with uncertainty and calculated risks that everybody else lives with every day.
That's perfect. And also, addiction, like any disease, like many diseases actually, is chronic. I used to get, my blood would boil when people would sort of expect a cure with like one episode of treatment. Or I guess people in the medical field would look at addicts and alcoholics that would relapse and think, it's a characterological flaw. But, there was a landmark paper that came out comparing outcomes of substance abuse to asthma, diabetes, and high blood pressure, and they found that they're all pretty much the same. So people with substance abuse disorder, more likely than not, will have a relapse. That's just like life. Like somebody with high blood pressure is going to have a relapse. Now, somebody with OCD, let me just pose this hypothetical, say that they've gone through ERP successfully and they haven't had an episode for a year and a half, and then they have one. Does that mean they have to go right back to treatment?
This is a question that we toy with every day. I was running relapse prevention group yesterday here, and one of the things that we spend a lot of time is talking about the difference between a lapse versus a relapse, right?
Yeah, I've heard that, right?
You're going to have lapses, and I actually would be shocked if you go a year and a half without multiple lapses. To me, a relapse is kind of like your return to baseline of before treatment. And so do you have to have a full-blown relapse? Of course not. But my goal is that actually when you have lapses along the way and you find yourself ritualizing, you find yourself giving in, that's when you would seek out treatment versus waiting until it's a relapse. And the answer is, in short, most people see amazing relief from ERP in about as little as 12 to 16 sessions. I myself went to inpatient treatment when I was 15 for 90 days, relapsed about a year and a half later, went back to treatment for a couple of months, and I still go to therapy every week, right? I'm 17 plus years